All right, so transcranial Doppler. So we actually have, nowadays, we have two forms of transcranial Doppler. So we have our original TCD, our transcranial Doppler. So this is non-imaging. So only get Doppler waveforms. So with this one, we use a 2 megahertz pulse transducer. And then the important thing to remember is that Doppler angle is assumed to be 0 degrees. So with this, we don't have that function or the ability, to angle toward the vessel because we really can't see the vessel. So with our traditional transcranial Doppler imaging, we just assume that our Doppler angle is 0. So all our velocity measurements are calculated using that assumption. But as technology progressed and advanced, we are now able to do transcranial color-coded duplex sonography. So this is the more modern transcranial Doppler that we do. So this is called TCCS. Color-coded sonography. So this combines our B mode with color Doppler, color and spectral Doppler. This one we use a 1.8 to 3.6 megahertz phased array. And what this allows for angle correct vessels. So with this one, we can angle correct and allow us to get, align ourselves parallel to the vessel, get our proper Doppler angles. So with further advancement of technology, we now are able to actually do 3D transcranial color-coded sonography. That's now an option. Now available. Let's get it, Morgan. And we also administer contrast agent to improve evaluation of intracranial blood flow. So we'll use contrast agent to improve visualization vessels. So why do we do this? Why are we doing transcranial Dopplers? So used detection intracranial stenosis and occlusion. Another indication could be screening of patients with sickle cell. You can use it to potentially detect presence of AVM. So AVM stands for arterial venous malformation. Arterial venous malformation. I'm going to highlight this one. One of the main reasons is going to be evaluating for something called vasospasm. Evaluating for vasospasm post subarachnoid hemorrhage. So we're going to go into a little bit later exactly what vasospasm is, but it's a condition in which when a patient has a brain bleed, that extra pressure from the brain bleed puts pressure on the vessels, causing a constriction or a narrowing of the vessel, and thus creating a stenosis and increasing velocities within the brain. So post a brain bleed or subarachnoid hemorrhage, transcranial Doppler plays a critical role in assessing for the presence of vasospasm because it can lead to compromise of the brain tissue. We also use it for detecting cerebral emboli. And as well as the detection of brain death. So in essence, this transcranial Doppler exam gives us a good overall indication of brain perfusion. Position. We have patient laying supine. Head slightly elevated. Patient may also sit preferred. patient must remain still. With little movement. And avoid speaking. I'll highlight this also. So before we do a transcranial Doppler, it's important for us to know the status of the extracranial arteries before the exam. So it's very helpful and useful to us if we know if there's any stenosis in the extracranial arteries before we begin our transcranial exam, because that'll give us an indication of, you know, which potential collateral pathways could be open or affected. So it gives us an idea, you know, where to look and what we should be looking for. So no status of extracranial vessels prior to TCD. So know the status of your ICA and vertebral arteries, your ECA. So if we go to our, you know, our picture of our circle of Willis, so we have our internal carotid arteries coming up and doing a loop around. So there are several segments, you know, to these vessels that can be broken up a little bit further. So our segment of our carotid artery, so blood flow is coming up this way. This segment is considered our carotid sinus. Carotid sinus. So then we have C3, C2, C1 for our carotid arteries. So our blood flow comes in, goes around the loop, and we wind up in the distal common carotid and our bifurcation. So the common carotid, distal ICA, Jesus. So our distal ICA, our distal internal carotid artery, then bifurcates or splits into our anterior communicating artery, anterior cerebral artery. Good God, bad morning. So this is our ACA, anterior cerebral artery, and our middle cerebral artery, MCA. So middle cerebral artery has two segments as well. The first portion is considered M1. The second segment is M2, the more distal segment. Our anterior communicating artery also has two segments. We have an A1 and A2, the more distal segment. So our posterior circulation, we have our vertebral artery. Comes our basilar artery, which then splits into our two posterior cerebral arteries, PCA. And with the posterior cerebral artery, we also have two segments. We have a P1, which is more proximal, and P2, which is more distal. So we have blood flow coming up our vertebrals into the basilar artery, which then splits into our two posterior cerebral arteries. So connecting our two anterior and posterior circulations, we have our posterior communicating artery. So posterior communicating artery, PCOA. And typically blood flow in that artery is going to be from the anterior circulation into the posterior circulation. So if you could draw this out and understand the circulation, the blood flow, the direction it's going in, it makes your transcranial exam much easier because you know what the normal flow directions are going to be. It'll help you to anticipate, the depth of the vessel as well, because those are the two main criteria when we're assessing, doing our transcranial Dopplers. We need to know the direction and the depth in addition to the velocities that we measure. So we have four main windows that we utilize for our transcranial Doppler. So the first window, windows, imaging. Our first is going to be transtemporal. So that's kind of like a side view of a patient's head. So this is his ear. So within the transtemporal, temporal. So within our transtemporal view, we have three windows. We have one that's more anterior. So we'll put a little one on here. That'd be anterior. Number 2, which is just in front of the ear. That's going to be periauricular. We have a window just above the ear, more posterior here. That's going to be a posterior window. We have our anterior window, periauricular, and a posterior window. So vessels imaged. The angle anterior. From this angulation, we're able to image the middle cerebral artery, the carotid sinus, the anterior cerebral artery, and the anterior communicating artery. The angle anterior, these guys, angle posterior, you can see the posterior cerebral artery, basilar artery, and posterior communicating artery. So we're angling posterior towards the back of the head. We're going to see posterior communicating artery, basilar artery, and posterior cerebral artery. So what I mean by angling anterior and posterior, so if we're have our probe or transducer on the patient's head, and we're tilting posterior, we're going to see those posterior communicating, basilar, and a posterior cerebral artery. If we angle more anterior, we'll be able to visualize the middle cerebral, carotid sinus, anterior cerebral, and anterior communicating artery. So angle anterior towards the front of the face, angle posterior towards the back of the head. And remember to utilize, your 3 windows. Don't be fixated on one window. You may not necessarily see the vessel from that particular window. So try all 3 of your windows. Your anterior approach, your periauricular, and more of a posterior approach. So the next window, second, is going to be transorbital. So as the name implies, we're actually scanning through the eye. And with this, the image the anterior cerebral circulation, the image, input ACA. The image ophthalmic artery. Distal ICA. As well as I'm going to put carotid siphon too, because you can also image the carotid siphon. So now if we're go back to our chart, we're coming periorbital, so we're scanning in this direction down at the carotid circle of Willis. So from this direction, we're able to see our ophthalmic artery. We're able to image our carotid sinus as well as our distal portion of the ICA. So this segment of the vessel, as well as a portion of our anterior cerebral artery. Third window. This one's going to be called the suboccipital, or also the transforaminal. I got suboccipital slash trans or ran. So this is the window that's going to be at the base of the skull, the posterior, base skull. Vessels imaged. That's going to be your vertebral and your basilar artery. Vertebral, basilar. And then the last approach is going to be our submandibular. And this one is used for imaging distal. They're used for distal, extra cranial, ICA. We also, for the submandibular, also can image small segment within dura. So the dura is that first layer of the skull. Small segment within dura or proximal skull. You can say proximal skull. So here in the lab, we were doing, I was having you really go almost submandibular, trying to get as high as you can, you know, in that carotid artery. So we're going to make our chart now. I'm going to start with transtemporal. So we'll do our middle cerebral artery. So first thing we're going to do is depth. The next is going to be our mean flow velocity. Last one's going to be direction. So we'll put for depth for middle cerebral artery, it's going to be 50 millimeters. Our normal flow velocity, or our mean flow velocity, is going to be 55 centimeters per second. And our flow direction is going to be towards. If we go back to our little chart, the image, we're doing transtemporal, so we're coming in, there we go. So we're imaging transtemporal. Our ultrasound beam is headed inward towards that middle cerebral artery. So our middle cerebral artery blood flow is going in this direction, coming in this direction. So blood flow is coming towards our transducer, it's coming towards our ultrasound beam. So our flow direction is going to be towards us. So our next vessel is going to be our anterior cerebral artery. This one's going to be deeper. So our reference depth, I'm trying here reference, our reference depth is going to be 70 millimeters. So if you go back to our chart, if we're imaging transtemporal, our anterior cerebral artery is going to be deeper, so we got to scan deeper. So our reference depth is going to be now about 70 millimeters. Our mean average flow velocity for this is going to be 50 centimeters per second. And our flow direction is going to be away. Then we have the Mca, Aca, bifurcation. So our bifurcation is going to be our segment of vessel over here, where we now get a split of the internal carotid artery. So we have our ACA branching off, going away from us, and our middle cerebral artery continuing to come towards us. So for this, our depth is going to be between 55 and 65. Millimeters. Our velocities are actually going to be variable. And our direction is going to be both. So this bifurcation has a very unique waveform. So you're actually going to be able to visualize both vessels at the same time and get a waveform tracing of both. So we'll put it, let's draw it over here. So that bifurcation waveform going to look something like that. So you're actually going to pick up both vessels, and that is used as your landmark. So back when we didn't have the imaging capabilities to actually be able to visualize the vessels, the sonographer would use that bifurcation kind of as like your basis point to begin your exam. If you're able to find this waveform where you're able to image, the bifurcation of both the ACA and the MCA. So if you're able to look at this waveform above the baseline, would be coming towards you. So that would be your MCA, your middle cerebral artery. And then the waveform below the baseline is going to be your anterior cerebral artery going away from you. So typically you would use that as your reference point to begin your imaging. And then, you would advance, you'd know that, you had to kind of angle or scan deeper and come more anterior to image your anterior cerebral artery, angle more posterior to image your middle cerebral artery, and with a shallower depth. All right. So transtemporal, we can also image the distal ICA, also called the terminal ICA. So that would be our segment of the ICA when we're coming around that turn before the bifurcation. So this is going to have a depth of 55 to 65 as well. We'll have a mean velocity of 39 centimeters per second. And this is going to be towards. We also have our posterior cerebral artery. So this has a reference depth of 70 millimeters. It's going to have a mean flow velocity of also 39 centimeters per second. And this is also going to be towards us. So I'm going to break this up. So put a PCA1, so that first segment. So PCA1, and we're going to do PCA2. So PCA2 is going to be our distal segment over here. So if our transducer transtemporal is going to be, in this general location here, we're imaging back at that posterior cerebral artery. Our P1 segment is going to be towards us. If we image more posterior into that P2 segment, that's actually going to be tailing away from your transducer now. So our P2 segment is going to be away. This reference depth is going to be 65. The mean flow velocity is going to be 39. All right, so then transorbital. Our reference depth is going to be 45 millimeters. Mean velocity is going to be 21. This is going to be towards carotid sinus. Carotid siphon, sorry. This is going to be, I'm sorry, 41 for mean velocity. It's going to be towards our depth is 65. So I'm just putting over here siphon, carotid siphon as well. I apologize. So that segment over here, carotid sinus, carotid siphon, also. Carotid siphon.
They're like the same thing, just different words.
Yeah. I don't want to confuse. I have both like nomenclatures here. Then we can also visualize from that window our distal or terminal ICA. ICA. That's going to be away. It's going to have 47. Reference depth of 70. And the suboccipital, so that's that posterior window. We'll have our vertebral artery. tubular is going to be between 50 and 70 millimeters, depending on, the segment that you're imaging. The mean velocities for vertebral is going to be 38. It's going to be away. And then our basilar artery. This one's going to be deeper now, so this is going to be 70, 20. Slightly higher velocity at 41. And this one is also going to be away. Affecting velocities. So some of the things that can affect velocities. So the first is age. The younger patient, faster the velocities. Increase velocity with decrease in age. So inverse relationship. There's actually a chart in the slides that shows normal velocities with age, and the normal velocities in a child are much, much faster than what they would be in an adult versus a senior patient. Another thing that can affect blood flow velocities is gender. So cerebral blood flow velocity has been reported to be 3 to 5% higher in females. Gender. So higher velocities. Females. To 5% higher. Vessel diameter is another thing that can affect velocity. So vessel diameter, decreasing diameter equals increasing velocity. So the smaller the vessel, the faster the velocity. Think of it as a stenosis or a narrowing of that vessel. Another thing that can affect velocity would be our hematocrit. So our hematocrit is, how thick our blood is, the number of red blood cells within the blood. That plays in with viscosity. So a higher hematocrit will mean a lower flow velocity. So with hematocrit increase, equals decrease velocity. So decrease hematocrit an increase in velocity. So this is part of the reason why we do this exam for patients with sickle cell. So sickle cell patients will have a low hematocrit. So that's sickle cell. Low hematocrit. Sickle cell, low hematocrit. Example of a patient that would have high hematocrit would be polycythemia. I'm gonna write that over here. Polycythemia. High. Polycythemia. Sickle cell low hematocrit will result in elevated velocities, high velocity flow. Sickle cell, low hematocrit, high velocity flow. Polycythemia would be an example of a patient with a high hematocrit, which will result in a lower velocity flow. So other things that can affect blood flow velocities would be our blood pressure, BP, increase BP is associated increase systolic velocities. So CO2, so that's our carbon dioxide concentration in the blood. So if our PCO2 increases, this will cause blood vessels to dilate. And increase flow and velocities. Other factors could be cardiac output,
Hey, Dan, I have a question.
yeah,
So if a vessel dilates, that means it gets bigger, right?
yes.
So that's just a little confusing because I thought that with vessel diameter, if it got smaller, the velocity would increase. So
I was just about to ask that.
how in this
Good. No,
situation does it get
yep.
bigger and it increases?
Yep. So no, that's a good explanation. So when they're talking about vessel diameter, so the vessels within the brain, if they become more narrow,
Mm-hmm.
it's kind of viewed as it's viewed as a stenosis or a narrowing of that vessel. So
Okay.
the blood velocity is going to have to increase, or the velocity is going to have to increase to get through that narrower vessel.
Mm-hmm.
With regards to increasing with our CO2 levels, this is going to cause a global dilation of vessels throughout the body.
Mm-hmm.
So you're going to wind up with more blood volume getting to the actual brain. So this affects all the vessels in the body,
Okay.
whereas vessel diameter is more specific to the individual vessel in the brain. So a
Okay.
narrower vessel in the brain will have increased velocities, but this increase in the carbon dioxide in your blood will cause all the vessels in your body to dilate. So, including your aorta, your carotid arteries. So you're going to have increased blood flow volume getting to the cerebral vessels. So that increase in blood flow volume will cause an increase in velocities because you now have more blood flow trying to get through those vessels. So that's what that explanation is for like increasing CO2 levels. But no, that's a good question. You think too, like, I would imagine that the velocity increases wouldn't be as significant as, say, having a narrower vessel. But the pathophysiology behind it is, you would have a significant increase in total blood volume getting to those vessels. So I'll put increased flow volume. That's good. That's the big part of that. So that increased flow volume will lead to increased velocities. So some other factors could be cardiac output. There could be metabolic factors. Indications. So that one, highest velocities are almost always MCA, or middle cerebral artery. Or ACA, anterior cerebral artery. So those velocities I gave you are a mean average. There is a range that's considered normal. I'm not going to have you memorize that range because that would be a lot. But we will eventually get into what's our criteria for abnormal. So velocities above a certain threshold then become considered abnormal. So highest velocities are most always seen in the MCA or ACA. So posterior posterior cerebral artery and basilar artery. Smaller Doppler shifts. So that's another way of saying lower amplitude waveform. It's another way of saying lower velocity. Well, physics talk. So a small Doppler shift so that's going to mean the same thing as having a small amplitude. So the height of your wave, which equates to a lower velocity. So a small Doppler shift. So the greater the Doppler shift, the greater that velocity of the blood flow coming towards you, the greater the amplitude or the height or size of your waveform. right, so I'm just gonna break this down. So middle cerebral artery, put 60 centimeters per second. We'll put ACA 50. Posterior cerebral 40. Basilar 30. Cerebral 20 centimeters per second. So we can use this kind of as our general rule of thumb for velocities. We can see our fastest velocities are in our middle cerebral artery and anterior cerebral artery, slower in our posterior circulation. But we do notice that velocities increase as we move through the segments. So vertebral is going to be our lowest, increases a little bit when we get into the basilar, increases further when we get into posterior cerebral. This may help you to try and break down some of these questions. All right, so I'm going to stop here. I don't want to get into abnormal and pathology until we have a good handle on the normal and just really understand our circle of Willis. Getting into pathology is going to be a little much. And I'm going to have time with the scanning applications class to review our cerebrovascular circulation. So that's part of the lectures that we're going to do. So I'd rather take our time and do that properly over the summer and try and bombard you with a lot of pathology. So at least like when you get into doing your transcranial Doppler rotations in the hospital, you can understand your windows, understand which vessels you're imaging from the windows and your normal velocities. I think that's a good foundation. And then we'll get more into the pathologies during the summer.
Is this normal stuff that we just went over going to be on the final too?
Yeah, for anatomy and velocity and direction and depth. Yeah, those charts are, unfortunately, those charts will become your, they'll become ingrained in your brain. You'll remember them. But yeah, definitely understanding your flow directions and your anatomy and your windows. So Thursday for lab, I'm going to, it's basically like a makeup day. I have people coming in during the week to make up competencies. If you're missing, you can come in, schedule with me if you need to make up, do competencies here in the lab. Thursday we can go over stuff in preparation for the final. I mean, I'm here all day, so is there any topics that we want to go back over? We don't have necessarily set lab times. But I'm going to be like reviewing stuff here, we can go over stuff here in the lab. I'm definitely open to that. I don't want any tricks or surprises or I think we're pretty good with like the venous stuff. I think you guys have a pretty good handle on the venous stuff. Maybe we can go over some pictures for like DVT, the different types of DVT. We could maybe review over some of the additional venous testing, maybe go over fistula again.
Cool.
Cool. Any questions? No? Well, that's all I've got for you for today.
All right, thank you.
All right. Thank you.
Thank you.
Thank you.
Dan,
Yeah.
so I guess Kim, Megan, Morgan, and I were gonna come in. We scheduled some time for the PVR after Lauren and Krista
Sure. Yeah.
tomorrow. Will you be around?
Yeah, I'll be here. Lauren, just goes at 10:30. So yeah, after 10:30.
Yeah.
Okay. Yeah, I'm here.
All right.
Thank you.
All right.
Thank you.
See you tomorrow.